You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. And I want to thank you all so much for joining us on this episode. Today we'll be discussing fertility and cancer care for AYAs, or adolescents and young adults, covering the long-term physical and emotional impacts of treatment, timely counseling, insurance and access, cultural considerations, and coordinated care. We're delighted to be joined by two guests, Dr. Irene Su, who is a professor of obstetrics, gynecology, and reproductive science in the Division of Reproductive Endocrinology and Infertility at the University of California, San Diego. She directs the Oncofertility Program and co-directs the Moores Cancer Center Leadership Academy and the Center for Obstetrics Gynecology Research at UC San Diego. Also want to welcome Pam Simon, who's a nurse practitioner and program manager at the Stanford Adolescent and Young Adult Cancer Program at Stanford Medicine. Irene and Pam, thanks so much for joining us.
Thank you for having us.
Thank you so much.
Let's start the conversation just talking about AYA group and how are they different from pediatrics and how are they different from adult medicine? What's special about this group? Pam?
Yeah, thank you for having me. It's great to be here with Irene. She and I have worked together many times with this topic, especially. Adolescents and young adults in the United States, they're defined as 15 to 39 years old. So you can imagine all of the milestones and many things that are happening during this time period. When cancer comes along, it can make it much more difficult. And there are many unique needs for this population. And one of them we're talking about today is fertility.
Absolutely. Irene, what's your perspective on that in your practice?
Yeah, thanks also for having me. And it's great to be here also with an old friend, Pam. With respect to adolescents and young adults, those who are so young at the time of their cancer diagnosis, I think that for the most part, many people may not have considered what their families are going to be like in the future or haven't completed their families. And at a time, either when you're newly diagnosed with cancer or in survivorship, they're having questions about what does life look like after cancer. With respect to fertility, it's really because some cancer treatments, but not all cancer treatments, can harm the ability for a young man, a young woman to have a family later. And we're well positioned to try to understand who's at risk. And for those people who are at risk, help them have better options post-treatment.
Let me ask some general questions that may be a little bit unfair, but with the spectrum of cancers that occur in this age group and with the treatments that are available in this age group, roughly what percentage of patients will infertility issues potentially come up as a result of their treatment? Very common, uncommon, or how do you look at that?
I think we really look at it based on two things, based on the type of treatment that that patient is receiving, and at least on the female side, on their age. So it's hard to give a ballpark overall number, right? Because treatments are so different. But for example, we know that any preparative regimen for stem cell transplant, that's a more than 90% chance of sterility, whether you're female or male. So that's a high-risk population for us. Whereas frontline treatments for leukemia, those people who don't relapse, they don't really increase infertility risk. So it's kind of runs the gamut for me.
And I think that when we talk to these patients, that's what's very important, is helping them understand their risk. But then more importantly, where are they in this conversation? What do they want to do? You know, it's a little different when they're having cancer and going through all of the things they're going through with a diagnosis and thinking about fertility preservation. Very different than oh, I'm going to freeze my eggs, right? There's a lot of other things to think about. And I think that's why it's so important to talk to this population. Give them the information, let them decide what's right for them.
Let me ask you about the words that you use. So, for example, for a young AYA, and you mentioned earlier, some who've really not even considered this as a topic. How do you introduce the topic to them and let's say their family, their parents or guardians?
I can give that from the reproductive endocrinology or fertility specialist perspective. And then Pam is going to have a great segue into how to approach in the first place. I think it's such an honor to be a fertility specialist in the care of young people with cancer. And the way I segue into it is one of the reasons why you're here is because your oncology team thinks that you're going to have a long and healthy life. And we get to talk a little bit about what that life might look like. Some people know that they want to have a family and they want to have a specific kind of family, but other people don't know at all. And I think that we know for a long time now that other young people who have undergone this journey as you have wanted to know what their risks would be up front. And then the goal of today is to decide whether those risks, along with what you wish, helps us to decide, do you need to freeze sperm? Do you need to freeze eggs? Put your ovaries to sleep, or just watch and wait?
Got it. Pam?
Yeah, and I come from the oncology side of things. And so I also talk about that. I think the first thing I talk about with these patients is tell me a little bit about yourself before you got diagnosed, right? I don't jump right into fertility because often they're just so overwhelmed at this point, trying to understand who they are as a person. And then talk a little bit about AYA in general and being an adolescent and young adult and what that means when a cancer diagnosis happens. And then what kinds of topics we want to talk about. And then that's kind of how I introduce fertility, talking about, do you have any plans? Because even as young as 15, they may want to be a mom. They know they want to be a mom. Maybe that's the extent of their sort of thinking about having kids. And then all the way to the gamut of, I have no idea if I'm going to have kids. But I don't think that matters as much as we want to talk about what kind of an effect this cancer treatment might have on your ability to have children in the future. Just like we would talk to you about, is it going to affect your heart? Is it going to affect your liver? It's the same exact thing, but we're talking about fertility, and then go into the effects and the risks and that type of thing.
For the patients who say no, and obviously there's a lot of nuance based on age, but for those who say no, which I've had in my own practice over many years, what's your approach there? Obviously, I think we all want to respect autonomy, and yet being older than some of our patients, we might feel differently about it. So, Irene, let me ask you that one.
Yeah, actually, that figures nicely into the newish ASCO fertility preservation guidelines from last year, which is that how a person might feel in one moment isn't necessarily how they feel long term. And that's why late effects, including the impact of treatment on fertility, should be discussed longitudinally. And there are tools built, for example, in our electronic health record system to remind us every year to discuss this with our patients. But at the upfront consultation, no matter what I talk about, this is the first time that we're meeting. And regardless of how you choose, we're going to meet again post-treatment. For females especially, this is because they might have impaired ovarian function. That has nothing to do with fertility, but their long-term heart and bone health. And so I usually say at 6 to 12 months post-treatment, I want to see you again so we can rediscuss these issues and see how your ovaries or how your hormone function is going.
Yeah, as I'm listening to it, how it makes that second or even third visit more natural. So I can see that, and it's nice to line it up that way. Pam, any thoughts on that?
Yeah, I think also that what we talked about when we introduce ourselves and start the conversation is important, because I think that's what we want to make sure is that they don't regret this decision in the future. And I think just bringing that up and talking about making sure that they have the information so they can make the right decision. And the right decision is what they make. And it may be different now than it is in the future. But for most patients, at least what I see, and when I see them in survivorship, if they got the information and they made the decision, they're able to figure it out in the future, no matter what happens, because they know they made the best decision they could at the time.
Absolutely. So, if you would sort of walk us through what happens, an AYA patient gets admitted, let's say with a very acute oncologic problem, acute leukemia, or a high grade lymphoma. What happens then in terms of actually connecting with the patient, getting the referral, and what are the logistics and how do those occur?
I can start with that one. So I get a lot of referrals from the inpatient perspective. And I think for the most part, refer them all. It doesn't matter how sick they are. We then figure out a way to talk to them. I've been in the ICU. I've been in a lot of different situations that are not exactly what you would say ideal. But I think it's important, like I said, that they get this information. And if it's too much at the time, the patient or the family or somebody usually helps with this decision. But we try, like Irene said, is to talk to everyone so that they know that they have a choice. And sometimes, as we know, cancer takes away things and sometimes may take away this option for fertility preservation. But at the least, we want to give them the information and everything that we can prior to them starting treatment.
I think I would just add to that. I totally agree with what Pam has shared. I think the key really is at that screening spot. The moment that you think that someone might have a blood cancer or a cancer and they're inpatient or outpatient, then along the way, I think you would hopefully have identified a fertility team or specialist in your neighborhood. They may not be at your institution, but in your neighborhood who loves this population as much as you do. Then when you identify this patient, then it's that referral. And whether it is in person in the ICU from someone like Pam or by telehealth, we reach across 3 institutions, for example, here in San Diego. In that way, we can do that consult. That consult not only talks about fertility risks, but also about, for example, menstrual bleeding control, about contraception, kind of all things related to reproductive health. And that hopefully also helps the oncology team in being able to, for example, control bleeding.
Absolutely. Absolutely. So again, patients admitted they're acutely ill and they say, yeah, I want a sperm bank. I want to be able to be a parent. And let's make it maybe in some ways a little more complicated. A woman who says, yes, I really want to preserve some ovum. What's the timing for that? How much time do you need? And then I'm also going to ask you, because fertility treatment, at least in other settings, is profoundly expensive. So, yeah, tell us about that if you would.
So much to unpack there. Can I start? And then Pam, you'll just
Sure.
You'll make it better. So options for males are getting better and better. The collection is less challenging. It's important for males to have a private place to do this, particularly for adolescents, right? And then reproductive or urologists in your neighborhood could also help with testicular extraction if they can't ejaculate. But one of the reasons why technology is better is because there are these mail-in sperm freezing kits. For example, through the Veterans Administration, they no longer have andrology labs because they can just use this mail-in service. So that makes it super easy, really a private place to collect. And then the new guidelines are considering collecting more than once, because if you collect once, you can aliquot the sperm, but you may not have as many options for a female partner in the future. For females, it's a lot more complicated because, as you know, it takes about 2 weeks to get eggs out. And I'm no oncologist, but in the event that the oncology teams can support us for those 2 weeks, it really means having their platelets and their hemoglobin high enough to do the retrieval. Much of that ultrasound and blood work is done outpatient. So you need to be in a center where they're comfortable taking care of a medically complex patient.
Yeah.
And if there's not time, then we have to wait until after treatment. Some patients who go on to transplant, there's an opportunity for ovarian tissue freezing between consolidation and preparative treatment for stem cell transplant.
I totally agree. The home delivery kits have made such a difference. It's so much easier to use those inpatient than try to get a fresh specimen to a urology or fertility clinic. And so These kits have a fertility preservation liquid in them that then will keep the sperm hopefully healthy until it gets to that lab. It's a little logistics, but we figure that out. And there is a way to do that in these hospitals. And that would include in community hospitals could get that set up through these labs. So it doesn't really have to be through fertility clinics or oncologists in big academic centers. And I think the other piece that Irene mentioned earlier on was if the females aren't able to do anything by suppressing the ovaries, we don't know for sure, but we hope that there's some kind of a benefit there for fertility. At least there's something that we can do to try.
Let me ask you about the data on that. What's the latest? Does ovarian suppression preserve ovarian function? Do we know?
We know it for breast cancer patients from POEMs. And thank you for bringing up, Ken, a COG and multi-network trial that's happening now, randomizing non-breast cancer adolescent and young adult females who are receiving alkylating agents to ovarian suppression versus not. So there is an ongoing trial, and we can't wait to see the results. This is led by Eric Chow at the Hutch.
Yeah, and it will be interesting because it's been a question for a very long time. Let's go back. This is a difficult topic, but patients have said to me in the past, yes, I've done sperm banking, but cryopreservation or ovarian tissue preservation is going to cost me X number of dollars a year. How much does it cost? Do either one of you have a concept of that? And what are some resources for patients?
A year ago, Pam and other leaders in the field, we met here in San Diego to talk about, because at this point, there are 21 states and the District of Columbia that have state-level laws mandating coverage of fertility preservation services for people with cancer. So we wanted to understand why California, which is one of those states, has such a mandate, but it may not be working as well as we think. So this could be hours and hours, but essentially, I think from the patient and the clinician perspective, it is that some people will have coverage. So you got to go find out, because that coverage could mean the same copay as you have for any other oncology service to high proportions of cost sharing. So there's no good estimates. We're working on that. But the idea is you got to ask. And how you ask, of course, is by either calling the health plan or looking on their plan handbook and looking for the word fertility preservation. Big resources that are accessible is there's a place called the Alliance for Fertility Preservation. They keep a map of every state that has a mandate. And if you click on your state, you can see the characteristics of that state. Through a website called oncofertilityrisk.com, actually have a transcript that patients can call and use those words to figure out if they have benefit coverage or if a navigator wants to do that. So I think that if you're going to have health insurance and there's going to be coverage, you're going to hopefully increase access. Cash costs of freezing sperm is probably somewhere between $400 to $600. Egg freezing, I think this varies a lot. I think in some states as little as $4,000 to $5,000, in other states $10,000 to $12,000. Keeping gametes frozen every year is hundreds of dollars. But of course, if you have insurance coverage, there's some states that have been very generous with what's covered and actually requiring storage until that person is, for example, 26.
Very interesting. Thank you. I want to ask about disparities because we see it in all other parts of oncology care and medical care, but how about infertility?
For sure. And I think Irene has been a huge leader in this field, because I think she mentioned the fact that a lot of insurance companies don't cover this, and government insurance often doesn't not cover this. And so it can be very complicated for the patient. It can be very complicated for the people who are taking care of them, trying to help them as well. But I think it's important for us to try to look at where are these disparities, because at least in my experience, many patients say no strictly because of the cost. And I don't blame them because it's not just the cost of cryopreserving and storing. You also then have to think about the cost of using that in the future as well. There are grants, there are things out there, but someone has to help these patients find those, apply for those, figure out how to do all that as well. And so I think AYAs just in general are going to be the ones that are the least insured. This population of patients are the least insured. They're going to not be able to work often because of their cancer. They have huge financial toxicity, and not just right at the beginning. Sometimes many of them do already at the beginning, but
Yes.
it gets worse through survivorship when they're trying to find a job, when they're trying to figure out what's next. And so I think that we have to be very careful because there are some populations that are going to be even worse. And I think we know that throughout this population of patients, there are huge disparities. And I think some studies, we're starting to get some of that research, but I don't think we've even really touched it yet.
If I can add on to that, I think said in a similar way, what Pam is saying that the first disparity, at least in terms of reproductive health care, comes from your insurance status. And so, for example, we all know that in California, in this age group, it's 40-50% of people who are publicly insured. So when our mandate does not cover publicly insured people, then none of the people who are publicly insured have access to fertility preservation unless they pay it out of pocket.
Yeah. Yeah.
The second is language, cultural, right? Because people understand fertility and family building in different ways, and to have culturally appropriate, language appropriate materials. And then the third, I think particularly for females, is going to be because if you undergo egg or embryo freezing, that 2 weeks is frequent ultrasounds, frequent visits. You need to have resources. You need to be close to a place that you can be monitored, right? So there's some structural barriers to care well beyond just health insurance alone. And this is really hard for the population. We got to work on it.
Absolutely. As you're talking today, I'm thinking about my own practice. I practice in a community setting and a very small practice. And I'm thinking, you know what, geez, my patients, of course, deserve the same opportunities. So let me ask you broadly and some specifics too, but how should this be systematized? What are some of the key elements? Let me ask you that, Irene.
I think that there are really 4 key steps. So the first step is you got to screen every patient. And so whether you have a paper chart or you're in some electronic record system, it is possible to put an element of oncofertility screening, like for future fertility needs. And everybody who is ambivalent or has an interest should then be referred to fertility. So the systemized way is ahead of time. Step 2 is that there is a relationship so you know who to refer to in your community for both males and females. And we talked a bit earlier about for males, it could be with sperm collection kits that folks like Pam and I can kind of help you to be in touch with and systemize that. The referral should go with how much time you're going to give the fertility specialist and what is the treatment so we can counsel on risk. So step 1, screening, step 2, referral, and referral with fidelity, meaning that hopefully the referral doesn't go nowhere and nobody knows whether it ever got there. Fertility clinics are so happy to see these patients. They can really take the ownership over once they receive a referral. You can ask them to let you know they got the referral and what's happening with the patient. Then, from the fertility clinic standpoint, step 3 is after doing the risk counseling by telehealth or in person and talking about fertility preservation services, there's financial navigation. They should be helping the patient understand, do they have insurance coverage or what other resources can they access? And then the last step is also at the fertility clinic, which is undertaking fertility preservation services safely and then getting them back to our oncology colleagues for care.
Thank you. Actually, it's a wonderful summary. Pam, I'd love an example. There must be some degree of pleasure, excitement, pride in getting someone through all this. Can you share a story, an anecdote? Because I just think it would be interesting for myself and the listeners.
Sure. I have thousands of examples that are coming to me right now, but I think patients who are out in the community who get started diagnosed out in the community and then have to come to a big academic center like this can be very overwhelming. And so I think I can think of a young woman who was a adolescent, young adult, but going to go to transplant and having been treated prior and so already had risks to her fertility, but now going to a very significant risk of infertility. So, really thinking about some of the psychosocial needs as well, that this isn't just somebody who wants to freeze their eggs because they're 17 years old and don't really understand what that means. And so, really spending time talking about what this means step by step, right? What is this going to entail? That she can get through this, though it may be uncomfortable, right? What is a transvaginal ultrasound like? Really talking about, the real stuff, not just the top of here stuff, really talking about, are you going to be able to do this transvaginal ultrasound? And what can we do to help? And the fertility clinic's very good at that, being able to take time with them on that first ultrasound. But when I think about what is the biggest impact, I think it's spending time understanding where that patient's coming from. In this scenario, the patient was able to collect eggs prior to transplant, but it did take a little bit more of everybody's time, caring, understanding that this is a patient coming from a very different place than a 35-year-old. I'm not saying that that's not hard either, because many of my 35-year-old patients tell me that it was the worst experience that they had to go through, but they would do it again because it's so important to them and will be important to them. And I think when we see those patients being able to use those eggs in the future and have a children, I think obviously that's why we do all of this. But also, I think back to these patients who maybe aren't going to ever use them. Maybe they'll have babies themselves. Maybe they won't. Maybe they'll decide not to.
Yeah.
But like I said earlier, it's really about helping them through what decision they want to do at that time. And many of them say to me, I don't know what questions to ask.
Mhm.
I've never gone through this before. So we have to be the people who help them ask the questions sometimes, because they don't know. They don't know what they don't know, right? That's what they tell me. And so I think that's what really comes out to me, is that every patient is an individual and very different from the last patient. And so you can't really just throw here's what I'm going to say to
Right.
you, and have it as a script. It really has to be
Mhm.
individualized to every patient. And many patients
Absolutely.
have surprised me. Ones I think are going to do fertility preservation, but decide not to, and those who I don't think decide to. And so I think they teach me every day something new about fertility, but also that this is a lot about hope. And, when you're diagnosed with cancer, these patients get everything taken away from them, right? Everything is taken away from them. We tell them when they get chemo. We tell them when they get up. We tell them when they take medications. They have to quit their jobs, quit their school, whatever it is. And I think this is one choice. Fertility and deciding what they want to do is something that they can do for themselves, and something that is hopeful, whereas a lot of things we talk to them about aren't as hopeful. And so I think that's something that I take away every time from patients.
Absolutely. Thank you. Irene, actually, I want to go back for a minute, because in your career, hopefully there's many, many women who do go on and men who do go on a lot over a career. I'd love to hear a story of a patient who comes to mind where, again, let's say it's a young woman where you really had to potentially go through a lot, and yet she was able to successfully have children.
Yeah. Similar to Pam, I think we're humbled every day in the patients whom we serve. I would say one patient comes to mind because they're just coming back now. So this is a young woman who was also headed into transplant. She was a student at our university. Her family did not live close, nor had the resources to be here. Our oncology team, her clinician, was so set on helping this young person that essentially we were transfusing her through those 2 weeks, including the night before. And he arranged so that she could have her transfusion later in the afternoon so she wouldn't have to stay. But it turned out that because of the matching, she required an overnight emergency department stay in order to walk 15 minutes in the rain to come in for her egg retrieval because she didn't have a ride. And this student, because she's one of our own at our university, I think the whole team fell in love with her. And she's since graduated. She's doing well. she's met somebody and they've come back, and because she's menopausal, so we've had an ongoing relationship for menopausal hormone therapy, and she's met somebody. And now we are thinking about thawing those oocytes to make embryos and help her to conceive. And the thing of it is, because she was 21, a senior in college studying politics, at the time that we froze those eggs, we think that those are going to be good eggs. There's a good number of eggs frozen. We cannot wait to thaw them and transfer. We just have to figure out if that person is really her sperm charming. No, just kidding. He's great. He's great.
Well, I'm glad. I'm glad you approve. And I do like that, sperm charming. Wow. I'm going to walk away with that one.
Yeah, I have another thing to think about. I think partners are really important, whether they're married, may not be at this age, but I think partners are really important. And I remember a case where a leukemia patient came in, I think 33-year-old male, and he was very sick. And when I got asked to come talk about the fertility, he was kind of out of it, not in ICU, but just a high white count, very, very sick. And the wife, I remember walking in the room, and I remember the wife because she had a mask on, gowns, gloves, everything. And I looked around because I remember thinking, but I don't think I saw isolation on the front. And so I walk in, I look around, and nobody else has anything on, none of the doctors, none of the nurses, nothing else. And so I went ahead and just went to her and started introduced myself and started talking to her and just asked her, are you sick? Is that why you're wearing, a gown and gloves? And she said, no. Everyone just keeps talking about like how infection and how he can get so sick. I'm scared to touch him. And as I went through my whole fertility, she was like, I can't even think about, what are you talking about, kissing him or anything? Like, I will make him sick, right? And so long story short, we went through everything and talked about, yes, infection is a total risk, but we also want you to be partners together, and we want you to have a normal sexual life and all this sort of stuff. And she was just like, I can't believe you're talking to us about sperm banking at this time. I don't even know if he's going to live, all of that. And long story short, he was able to do a collection, just one vial. And obviously, with leukemia, you never know how healthy that's going to be, just because the whole body's not very healthy at this time. And I met with the wife. He ended up getting pretty sick. He got into ICU. He ended up going straight to transplant. I would come back and visit, and especially talk with her. And she wanted to talk about having children because they didn't have any children. I know people looked at me like I was crazy because he was so sick. They were like, why are you talking to her about this? But I knew that that was something she needed to hope for and to hold on to get through this period of time. Right. And so I would come back and talk to her. And luckily, he did well. He got through this. They now have 2 children from the one vial of sperm. And so I get a Christmas card every year, and I see these children growing up and them just flourishing. And so I think those kind of stories are amazing. I wish all of our stories were like that, but
I know.
it's one to remember.
Beautiful, beautiful. Thank you. It's a very broad topic, but what is the impact of fertility and infertility, which often is permanent infertility, in AYA?
I think that survivors of adolescent and young adult cancer who are infertile, I think that impacts the way that they can have relationships. Because when you disclose someone in a new relationship that you may not be able to have children, or that how you would imagine building your family in other ways, I think it's profound to many people who had imagined their family a certain way prior to their cancer diagnosis.
Yeah.
Yeah. And I think sometimes they don't know for sure yet, but they still need to date people, and they want to date people or meet people, right? And helping those AYAs go through, how are they going to disclose this? How do they want to talk to somebody they start dating? Maybe they don't know if they're infertile. Maybe they do know if they're infertile, but how can they have that conversation? Because I think they may not talk about it if we don't ask them about it. And so helping them be where they are and figure out what they need to get to where they want to be, I think is super important for these patients. And I think infertility is always going to be something that's, whether they know if they're infertile or not, they're thinking, am I going to be able to have children? And so I think doing what we can to help them post-treatment, like Irene mentioned earlier, post-treatment is almost more important in some ways because we need to talk to them. They're going to feel different after. They're going to have different questions after treatment about fertility and infertility. So making sure that we can reconnect with them after treatment is very important.
Absolutely.
There's something to add to that. As you know, there's a finite amount of eggs that females have. And for some people who were exposed to pretty gonadotoxic treatments, they still might have some ovarian reserve left, but it's smaller and they're going to run out sooner. So that's one more plug for post-treatment survivorship care, that there may be an indication in a second opportunity to freeze eggs or embryos at least 6 months post the end of treatment for those people who might be early.
Wow. Thank you. That was great. Absolutely wonderful. First, I want to thank everyone for listening to this terrific episode that I think was informative and meaningful on many different levels. So with that in mind, I want to thank Dr. Irene Sue and Pam Simon for being with us today. Thanks so much.
Thank you for having us and highlighting this area that we feel so passionate about.
Yes, thank you so much. It was wonderful.
And I want to thank also all of our listeners for tuning in for this incredible episode. For a listing of all of our healthcare professional continuing education activities, including webinars on AYAs, survivorship, and more. We also have podcasts and healthcare professional resources, including a fact sheet on blood cancer survivorship. You can visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families that can be found at bloodcancerunited.org/support. Finally, I want to encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.